Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I'm Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. It's so great to be with all of you today. For those of you joining us for the first time, welcome. Be sure to subscribe to our podcast on iTunes, Spotify, or wherever you download your content. And please be sure to follow us on social media at Breast Cancer Conversations. For those of you who tune in each week, it's great to have you back. I love that you're tuning in, and please keep sending me those text messages and emails with your takeaways. It truly fills my heart to know that our podcast is making a difference. I feel compelled to provide you with as much information, support, and resources as I can through our show, our interviews, and my own personal experience with breast cancer. This is a passion project of love, and love it has to be. The interviews and connecting with you, our listeners, and our audience is the fun part. But there is a lot of sweat and joy that come from the relentless hours of post-production and editing we do each week to bring our podcast to life. I'd like to thank our patrons of the podcast. Patrons are folks who listen to the podcast, believe in the podcast, and support the work that we do. They make monthly contributions through Patreon. Patreon is basically a platform where you sign up for these monthly contributions, and in turn, you get access to exclusive benefits, such as access to a closed group discussion board, opportunities to ask questions for an upcoming show, or even participate in live calls. If you would like to be part of this community, go to breastcancerconversations.org/support to sign up. This is part 2 in our McGee Women's Research Institute and Foundation series. During our visit to McGee, it quickly became evident that their doctors, scientists, researchers, and physicians partner not only with patients and health advocates, but also their community to provide the best treatments and opportunities to those who have been diagnosed with cancer. Collaboration would be an understatement. How many of us have a line in our cover letters and resumes about collaboration? We state that we are a perfect fit for the company because we can work both independently and cross-functionally on teams. We've all been on that job interview where we get asked, "Tell me about a time where you had to work in a group to accomplish a goal." We paint the perfect example. We talk about the give and take of relationships. We highlight our leadership skills of working on teams, and then we hope with our fingers crossed that we get the offer. It's one thing to say you collaborate, to sit in the interview chair and recall a time when. This site visit to McGee was just the opposite. We were speaking with their doctors, researchers, and administrators across disciplines working towards a common goal. This isn't a situation where we say we collaborate, but we are actually employing the virtue of collaboration through action and moving the field forward.
Get 15 of us in a room to brainstorm, fine tune. So here was my idea. Sure. You make it better. Now you show me your idea. I'll make it better. And so really trying to get the best of the best and then make them kind of be finely honed.
The researchers study the role of the immune system in causing and fighting breast cancer and reproductive tract cancers. They investigate biomarkers for risk, severity, and response to therapy, and conduct large-scale clinical trials of breakthrough therapies for cervical and ovarian cancers. In this episode, we jump right into a conversation with Dr. Buckanovich, where he highlights 3 major areas of need within ovarian cancer. We discuss the link between ovarian cancer and breast cancer, specifically if you carry the BRCA gene mutation. He shares some exciting developments found in treating ovarian cancers that could also potentially be an option for those who have been diagnosed with triple-negative breast cancer. We continue the discussion on genomic sequencing, going beyond the standard of care looking just at DNA and zooming in on RNA sequencing. As I mentioned earlier, this podcast is a labor of love. Every interview, recording, and episode enables me to learn more, investigate topics that are important to you. I take what I am finding in the field and package it up in digestible sound bites for you to consume, learn, and feel empowered. Dr. Buckanovich has a similar approach. He loves his work, and it's that passion which drives him.
Having the research lab allows the intellectual stimulation, the creativity, where I'm always doing something new, at least in theory, right? Medicine, you get good at something by doing it over and over and over and over again. So you do the same thing over and over again. Whereas in science, once you've proven something, in theory, you don't keep reproving it. You move on to the next problem. And so it's a perfect marriage of kind of intellectual curiosity and excitement. But then I have the motivation of the clinic where I can see why I'm doing what I'm doing. I know why why what I'm doing is going to be important for somebody. And then at the end of the week, I get a hug. So my clinic is the end of the week and I get hugs. And so it's a great mix where I can kind of do the hard science and I can fight with grants. I was talking with the NIH today and so deal with those frustrations. The patients keep me motivated. And so the combination is fantastic. And so that's why I have the best job in the world. I love what I do.
Welcome to the conversation. So I'm so thrilled to have you on our podcast, Breast Cancer Conversations, today, because you alluded to this a little bit with BRCA mutations or different gene mutations, that there is a strong link between breast cancer and other women's health cancers, such as ovarian cancer, endometriosis, uterine cancer, et cetera. Especially in the breast cancer field, too. I know a lot of our colleagues are on, tamoxifen, and one of the side effects of tamoxifen is the potential of uterine cancer. I think it's still a small percentage, but it's still a list of the side effects.
Something we want to pay attention to.
Exactly.
Yeah.
So I just think this is a great way to kind of open the floodgates of stepping a little bit beyond the realm of just breast cancer, but talking about other women's health issues that are so tangentially related. So thank you for taking the time.
Thank you for inviting me. I'm Buckanovich. I am the co-director of the Women's Cancer Research Center and the cancer biology programs independent here at McGee Women's Research Institute and the UPMC Hillman Cancer Center. I'm dedicated my career to the research of gynecologic cancers primarily, but also with how they interact with breast cancers. We've gone nowhere, unfortunately, in ovarian cancer trying to find a good diagnostic test. There were a couple big clinical trials that were done, 500,000 women here in the United States, and that trial was a negative trial. That was looking at C125s and ultrasounds, and there was a similar study done in England, which was a very big study. And that study similarly that one's a little more optimistic, but really has not been a positive trial to date. It depends there's some fancy stats there, but it really wasn't the home run we were hoping for. So it's a little bit back to square one. That said, we've got some new technologies that weren't around when these trials started 15 years ago. And so using newer technologies, cell-free DNAs, microRNAs, link RNAs, things that were really just discovered in the last 10 years, trying to move those into the diagnostic space with kind of a unique look, kind of taking a different angle. There's been a lot of focus on the cancer cell, but it may actually be the body's response to the cancer cell, which is easier to find. So I've been using the analogy, if you think about a daisy, what you see is the petals. But if you consider that the cancer is the center and the petals are the response, and so we should maybe stop looking for all those little dots in the center of the daisy and be looking for the petals. And so we're kind of coming with a new spin, and we're doing this in collaboration with folks at Johns Hopkins, UPenn, and NYU in a consortium where we're doing via the DoD ovarian cancer program. And so that is something in the kind of lead time. So big area of need is a new diagnostic test. So that is something we're developing. I'm super lucky here at McGee, and one of the people who developed diagnostic tests for maternal fetal testing. So, used to be, if you wanted to diagnose a chromosomal abnormality in a fetus, you had to do an invasive procedure via the uterus, placental biopsies, things like that, which risked the pregnancy and people didn't want to do. Well, people developed ways to test the bloodstream because we know a little bit of the fetal DNA gets into the mom's bloodstream. And so one of the people who developed that test, which is now used worldwide, happens to be here at McGee. So we can take advantage of his ability to detect really, really rare events in peripheral blood. And now instead of looking for fetal blood, we look for cancer. And so we're trying to kind of harvest those expertise and reapply them into a new area. And so that's a really new, exciting, but just, really just getting off the ground now proposal. So that would be one major area of need. Another area of need is preventing relapse. Right? So in ovarian cancer, we're actually pretty decent. We can take even patients with advanced stage disease because it's so responsive to chemotherapy and our surgeons do such a good job. We can get a complete clinical response in 80% of patients. Stage 3 disease spread through the abdomen, we can get a complete clinical response with surgery and chemotherapy combined. Problem is that 70-80% of those patients will relapse. So kind of a holy grail of the field has been, how do you prevent those relapses? And we're making some headway for patients who are BRCA mutation carriers with the PARP inhibitors, but that's only 20% of patients. The other 80%, we really haven't dented much. We've tried more chemo. We've tried more anti-angiogenic agents. We need better ways of doing that. And so that's a real focus of my work is understanding some of those resistant cells what is it about the cells that don't die when we give chemotherapy, and trying to understand those. And they're a population of what we call stem-like cells. A little controversy there. There's also a population of quiescent cells, which we think are a subset of the subset of stem-like cells. And we're learning now that those cells, so chemotherapy, radiation therapy, they kill rapidly growing cells. But if a cell is quiescent, by definition, it's not growing very rapidly, and so it doesn't die. And we've been studying those very intently right now, trying to understand what they are, and then once we know them, so they are a small subset of cells, but once we find them, we can then figure out how to target them. And by targeting them, we may be able to prevent, if we kill 99% of cells, but we leave 1% behind, cancer comes back. But we can understand how to kill that 1%. It shouldn't be that hard, right? And so, but you got to find it first. And so we think we found the needle in the haystack, doing a lot of characterizing, but developing new drugs targeting those stem-like and quiescent cells. So that's kind of a big area of need. And then the last area of need is for those patients who do relapse, right? We need new drugs, new approaches there. We keep doing the same thing over and over again. I know once a patient has platinum-resistant cancer, I know that other chemotherapies aren't going to cure them. We need completely different out-of-the-box approaches. And so we're developing some of those. Some of those will couple with immune therapy. So immune therapies making great strides in endometrial cancer. We're seeing a very nice response with some of the immune therapies in combination with non-chemotherapy agents. So breast cancer, we're seeing immune therapy kind of finally starting to make a dent. It could be better. And so the question is, how do we make it better? So that's one area we're dovetailing. Again, taking, University of Pittsburgh has tons of expertise in immunology. People here, before I was here, were studying this when immunology wasn't cool. When everybody was like, oh, you're wasting your time. People said, no, this is going to work. And they kept plodding along. And so there's a ton of expertise here that we've been harvesting into. And so trying to kind of tap into that immunology space and see how can we make an otherwise non-immune responsive tumor better. And so we've got some approaches there. And then just kind of completely novel, totally new therapeutics we're trying to develop in the lab that look very exciting. They happen to dovetail a bit with the immune therapies. And so those are kind of the three big spaces we're trying to touch on. Breast cancer and ovarian cancer clearly linked via the BRCA mutation. So the risk of breast cancer tends to be about twofold the risk of ovarian cancer. For BRCA1, BRCA2, you can kind of take the numbers, 80-40 for breast, and then cut it in half, 40-20% lifetime risk for ovarian cancer. But, one of the treatments, in Europe, taking ovaries out is a way to help prevent recurrence of breast cancer because you're getting rid of that hormonal stimuli. We tend to do it pharmacologically here with aromatase inhibitors or other things, but removing the ovaries is a very effective and cost-effective way. So for countries that are, on a different budget, that's a very common way between this. There's clearly a link back and forth. And so some breast cancers actually like to metastasize to the ovary, which is unusual. So people don't realize that sometimes we get a patient, they think they have an ovarian cancer and they've actually had what we call a drop met, where a breast cancer can spread to the ovary. So there's clearly an intimate link between the two. And the other thing is a triple negative breast cancer. If you look at the molecular biology, so the genomics, and when people talk about the genomics, people have sequenced tumors. So what we do is we sequence the DNA of the tumor versus your normal healthy DNA. And we can look at that DNA and see what mutations are, what changes are that drive the cancer. And so it turns out triple negative breast cancer, which is the hardest to treat and cure, looks very, 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 very much like high-grade serous ovarian cancer, which is the hardest to treat and cure. Wow. So even at very down distilled at this very molecular level, there are tons of similarities. And so between the two, I actually think that we can take some of the things we've learned in ovarian cancer, and then we're trying to now back apply some of this stuff to breast cancer. And then the flip side is, the breast cancer community has been really, they lead the way in research. So the breast cancer patients, their willingness to be in clinical trials, their commitment to the community, it's amazing and the role model for all of us. But then we can learn a lot from, breast cancer's 10 years ahead of most other research fields in cancer, in part due to numbers, which is unfortunate. There are so many patients, but, we're curing a lot of breast cancer patients. We're curing more than not, which is such a good thing to say. And so then, I'm hoping in ovarian cancer, we can be where you guys are. So in 10 years, I'm hoping to be where breast cancer is now. Sure. And if we could cure that many patients, it would be, that's my whole goal, my whole career goal, is to get there. So
are you running RNA tests as well?
So RNA test so now when people do molecular tumor profiling, it used to be just DNA. but we realize that DNA is not everything. It's still important, but yes. So people, when you get most of these, there are, a bunch of these kind of fancy tests out there that can cost hundreds to thousands of dollars, depending on who it is and what's being done. But nowadays, more and more commonly, they also will do RNA sequencing because you will see, so for example, the BRCA genes may not be deleted or mutated, but they might be methylated, which turns them off. And so turning off is just as bad as being mutated and deleted because it, not there is not there. And so we do look at other ways. Some of it are more the genomics, the DNA is more standard of care, but more and more we are looking much more broadly. And that advantage that also offers a research advantage that we can take that information and start to say, well, what else is in there? We can start to see, because genes being there, how they're expressed matters. And so we're looking at microRNAs and link RNAs, and there's so many different approaches now to looking at these that, yes, there are more and more being done. Most of them not clinically actionable yet is the kind of that's the hook, unfortunately. But I think we're getting there. There's a scientist here who's able to take something called long non-coding RNAs. We call them link RNAs for short. And so we thought, well, the genome, if it doesn't encode a gene, it's just garbage RNA. It got made by accident. It's not supposed to be there. Well, it turns out it critically regulates hundreds of other genes downstream. And so you can actually take, there's a scientist here who's been able to take the link RNAs that are expressed by different tumors and based on that predict how they should respond to therapy. And so there's a ton to be learned in all the rest of the omics, not just genomics. There's proteomics and RNA-omics and a microbiome is even, that's a whole new universe that we're delving into that we really just know the tip of the iceberg now.
And what about the use of artificial intelligence with regards to your investigations?
So our group is not doing them per se. We probably should be taking more advantage because Carnegie Mellon University, which is right next door, is a world leader in AI. Certainly people are, and you can take, so there's a group of collaborators of ours who looked at microRNA in the bloodstream and basically took an AI approach and said, tell me what best predicts ovarian cancer. And you can do this for breast cancer, any other cancer you want. And people are starting to take these AI approaches. We always thought, well, it's got to be an intelligent way. It's got to be hypothesis driven, right? But, I sit on NIH study sections and there's still this focus. Every now and then I'm like, I will say, you know what? If this drug cures cancer and I don't know how, as a clinician, I don't give a damn.
Right.
I don't care how it does it as long as it does it.
Sure.
And so if we can take an AI approach that can say, take a bunch of random connections and put them together to equal diagnosis or cure, yeah, for sure, that is something that people are starting to look into. Yeah. But again, as AI as a field is really evolving in the last decade, applying a really complex thing to another really complex thing that is human cancer is going to take a little bit of thought, but certainly there are people going there.
I feel like we've swung the pendulum in different approaches. In earlier conversations in our podcast, we were talking about, when you get diagnosed with breast cancer, for example, the standard of care was just a radical mastectomy. And then now it's like, well, can we save some of the breast tissue or the nipple sparing, et cetera? And to tie this into a blog that we recently wrote about the Oncotype DX score, where now you can actually be testing to see the likelihood of a recurrence. Yeah. You may not necessarily be a candidate for chemotherapy. And then now not over-treating, for example. So, I think that's really positive as well. And even in just the 2 to 3 years that I've been on this cancer journey, I don't feel like I've been overtreated. We went on a very aggressive approach with my cancer. But at the same time, it's like, wow, how quickly medicine is evolving that, I'm learning now about the toxicity in my own body where, a person who was diagnosed a year after me doesn't even need half of the treatments that I was on. So it's moving very rapidly. And the tests, I think, are coming out and there's a lot of hope around that.
Yeah, I think that the less is more concept is a new concept in medicine.
Yeah.
But we are initially, the first do no harm, right? It's supposed to be kind of the first principles. But there is also a sense that when you meet with a patient and a patient's sitting in front of you for the first time, you want to do everything you can to cure that patient. And you don't want to have missed an opportunity. So I feel that physicians were early on and still are very aggressive and appropriately so, because we want to cure people when we have an opportunity. Mm-hmm. But then the question is, so I sometimes use the analogy of hitting a hammer into the floor. a nail into the floor. So you're hammering, and you can get the nail down to the floor. If you keep hammering, the nail's really not going any further, and you start damaging the floor, right? And so we got to figure out how to hammer the nail without damaging the surrounding patient, if you will. And so there is a, there's this, we want to be careful because we don't want to, undertreat and not cure people, right? And so, but I do think that we tend to overtreat. And this is something that I wrote an editorial in the JCO about how we're overtreating, we're overusing certain medications. If I'm not curing somebody with the medicine, then why not save it for later, right? Okay. If I'm not going to make a big impact now, why not save it for later? And maybe a bunch of patients won't need it, right? And it will do an advantage. We're trying to develop an assay here to predict which patients. So in endometrial cancer, we commonly use radiation, much like in breast cancer, where you might have a lumpectomy and radiation. But some patients are cured with that lumpectomy alone, might not need the radiation and the side effects that come with it. In endometrial cancer, we know that radiation isn't improving overall survival. It improves something called progression-free survival. So the question is, are there a subset of patients you just don't need it? It wasn't going to impact them at all. And can we find them via a molecular test, an omic test, something like that, much like, so I'm going to call it endotype instead of oncotype.
Yeah.
Right. Can we develop an endotype assay so that in an oncotype equivalent, because that's fantastic that we can do that in breast cancer. We can say, hey, you know what, you've got a very low risk of ever recurring and you don't need all these toxicities. Right. And so sparing toxicities and helping survivorship is a great thing. And so I would love to kind of move into it again. We're going to follow the breast cancer world and do the less is more approach if we can, but we want to do it without risking cures.
Absolutely.
Right. And so that's, it's got to be done thoughtfully and methodically. And so that's where we got, we don't want to risk cures because there aren't enough cures as it is. We don't want to risk the ones that we get.
What are the symptoms of ovarian cancer?
So ovarian cancer symptoms is tricky. So people have tried to develop kind of a diagnostic symptom signature score. The problem with the symptoms of ovarian cancer is they're really vague. So one of the number one symptoms of ovarian cancer is bloating, right? And most women who get ovarian cancer are postmenopausal. Well, numbers are roughly 40% or more of women who are postmenopausal have some bloating, right? And I don't want 40% of the world thinking they have ovarian cancer because they don't. They have some bloating. And it's so incredibly common. So the problem is the symptoms relate typically, unfortunately, to the spread of the disease into the abdomen. So you get bowel irritation. So you get changes in your bowel or bladder habits, bloating. Some people get some nausea, increased abdominal girth if they develop fluid, weight gain. So what postmenopausal woman doesn't complain about weight gain, right? So there's just all these complex symptoms that added up can mean ovarian cancer, but they're all nonspecific, And so it's like saying, well, you've got a headache, right? We all get a headache. It doesn't mean we've got brain cancer, but, can a headache mean brain cancer? It could, but it doesn't for 99.999%. So it's been really hard to find some way where you can tell a woman that, hey, if you got some bloating, you need to see your doctor. So people have started to say, if you get 2 or 3 of these symptoms and they persist more than 2 or 3 weeks, then you need to see your doctor. And so those are things that, so we don't want to downplay those, because if I've seen patients who went to their doctor and they said, oh, maybe you got a little bladder infection, they give them an antibiotic. And then they say, oh, maybe a little colon irritation, they get a colonoscopy. And then 6, 8, 9 months go by. And then they show up with 10 liters of ascites and ovarian cancer spread everywhere, right? And it was missed. That happens. May or may not have actually had an impact. The odds are it had spread. The problem is that when it spreads, ovarian cancer spreads, the abdomen's got so much room, so much leeway, that if you got a tumor sitting on a part of your bowel and you got 30 feet of bowel, you probably don't even notice it, right? You don't notice it till that tumor's grown the size of a softball, right? And now it's a big problem. And now there are, 20 spots instead of 1. And that's really where we run in these kind of buried body parts. They're harder to diagnose. Fortunately with breast cancer, we can do mammograms, we can do MRIs, we can palpate lumps, yet can't do that with an ovary, which is buried deep in the pelvis. Okay. Right? And so it makes it a lot harder to diagnose. And that's where a diagnostic test, if we could screen annually with a blood test, would be a godsend, to say, hey, I'm a little worried and you need to go have surgery and we'll just cut that out and you'll be cured. Right. That's the goal to get to that.
So even like an MRI, like there's no diagnostic?
There is no diagnostic test in ovarian cancer. So people have looked and so we've tried, there was something called the PLCO. It was a prostate cancer, lung cancer, ovarian cancer screening trial. And they screened, I think it was about 300,000 women looking at CA125s, which is a blood test. and ultrasounds, and that test did not improve the outcomes of patients. Even then, we found the disease too late, and it wasn't going to change. So there was a big test in England where they matched ultrasound with something called a ROCA, which looks at the CA125 blood test over time, and that has performed a little bit better. But as I mentioned earlier, it's not a definitive home run, and a lot of people have argued, and they put at this stage like 750,000 women on trial, and they've done an incredible study, but it's just not definitive, and it's just hard. And part of the problem is that we need a test that's really, really sensitive and specific, because the lifetime risk of ovarian cancer is still pretty low, right? There are about 22,000 diagnoses annually, right? So if we screen 100 million annually to find 14,000, right? We've got to be 99.9% certain, or else we're going to be doing a lot of surgeries on women who don't need it. And so that's where this, again, first do no harm kind of comes in. And so we can't be doing 200,000 surgeries a year to find 14,000 ovarian cancers. It would just harm too many, the other 186,000 women.
Right. You mentioned the recurrence rate for ovarian cancer. I'm curious to know, I was really everything to my expertise in breast cancer, right? I know we're put on for estrogen positive. You have aromatase inhibitors or tamoxifen, and there's kind of a big celebration when you get to 5 years, right? If you can be 5 years cancer-free, that's a great milestone. How does that translate into ovarian cancer? And when can someone, if they have been diagnosed with ovarian cancer, hopefully not expect it to return, but what is that window like?
So the window tends to be a smaller window. Ovarian cancer, unfortunately, about 50% or so will recur by 18 months, which is an ugly number, right? So if you get to that 5 years, you are in the minority. So the median overall survival is not quite 5 years right now. So if you get to 5 years, the odds that you're cured are higher. They're still not guaranteed. Do we see patients who recur 7, 8 years out? We do, but they're rare just because the majority, when patients recur, it's within the first couple of years.
Wow.
It's tough. It's tough. We do have patients. And I will say the good news is things like PARP inhibitors are making a difference, it appears. We still don't know about survival yet. So this is one of the things that I'm waiting. I would really like to see where we're curing more patients. But we have had a couple of big trials now where patients who are BRCA mutation carriers, after they complete their chemotherapy, if they get a complete response disease, they start these drugs called PARP inhibitors. And we've seen very, very, very good responses where patients much longer out than we would have expected. The disease hasn't come back yet. So we're all hoping that is going to translate into increased survival, at least for that subset. Mm-hmm. For the non-BRCA mutation carriers, I'm not so sure. And this is where we're actually going to do a study here saying, do you need to be started on treatment right away, or can we wait and save it later when it comes back? In case you're one of those patients, it's not going to come back. Mm-hmm. And so I think that's a really important trial, because drugs have toxicities. Even, the PARP inhibitors are better than chemotherapy, but they have real toxicities. And if you're going to take them for years, that can add up. Nobody wants to feel fatigued for 3 years, right?
Exactly.
And so we need to figure out the appropriate window. And then there's financial toxicity. Mm-hmm. We don't talk about this a lot, but these drugs cost $12,000 a month, right? And so if you're even covering 10% of your copay, it's a lot of money, right? And so a lot of patients can't afford that. Most patients can't afford that, and the healthcare system can't afford that. So we need to figure out how we're going to do this and kind of be more judicious in how we use some of our weapons.
Yeah. I know we were talking about the BRCA mutation. Are there other genes that people can be tested for that would be linked to ovarian cancer or endometriosis?
There are. So there are a whole panel of genes now. So most patients now, when they get kind of tumor testing, if you will, we do for genetic testing, the BRCA genes are by far the most prevalent. And they're the ones we're going to detect most often. But there are a handful of other genes which tend to fall in that pathway. They tend to fall in the DNA damage repair pathway, which also can contribute. And so when we check a patient's genetics, if we're worried about that tumor being genetically driven, we actually look at dozens of genes. And because, even if it's a small percentage, even if it's 1%, if you're that 1%, it's important to know because of the impact to your family. ATM, ATR, PALB, the BRCA-associated proteins, RAD51. So there are a bunch of we can list lots of names. Sure. But those are the ones, those are all the ones we think about that are going to be following the most common, ECAD here. And there are a handful of things, less than ovarian cancer for that one, but the PALB, the BRIP, RAD51, all those genes that are in the what's known as the DNA damage repair pathway. The idea is that the cells can't repair their DNA, which is why they ultimately end up getting cancer, which is why, BRCA mutations lead to cancer, is that ultimately the cells don't repair their DNA as well as they could, leads to more mutations. More mutations ultimately lead to more cancer growth or, cellular growth. But there's also why we can target them with PARP inhibitors, which have been a real blessing for a lot of patients with both breast and ovarian cancer.
There's a huge pre-Vivra movement now that are doing mastectomies prior to the onset of breast cancer. Now, if they're carrying that BRCA gene and they still have this terrific predisposition towards cancer, even though the mastectomy is typically going to be removing a lot of that issue with regards to breast cancer, it's not going to be removing the issue of potentially ovarian cancer.
No. So most patients, I think that, patients who are going to be aggressive in those lines, most patients, so we will recommend for patients who have BRCA mutations, there is very good data that a Salpingo-oophorectomy, so removal of the tubes and ovaries, will reduce cancer rates 90-ish%, depending on the trial you're looking at. And so it doesn't get rid of everything. Whether the cancer cells had gotten out before the surgery or whether cells somewhere else are growing is unclear. But yes, just like mastectomies can reduce the breast cancer rates 95%, the same thing will happen if you remove the ovaries and the tubes. The controversy in ovarian cancer right now is that, so we call everything ovarian cancer. It's actually fallopian, ovarian, and peritoneal cancers. They all get lumped into, quote, ovarian cancer because we treat them the same. They look the same. They respond the same. So we kind of lump them together. But it turns out that at least a good majority, we don't know for sure, but most of them actually probably start in the fallopian tube. They then metastasize, spread to the ovary, and then from the ovary, they use the ovary as kind of a springboard to dive throughout the abdomen. And so there are a bunch of studies going on right now looking to see, can we do a stage procedure where we take out just the tubes? Mm-hmm. So can you do salpingectomies, take out the fallopian tubes, if that's the primary source of risk, leave the ovaries in to help protect the bones and the heart health and all those other things until 50 or, postmenopausal, and then take the ovaries out as kind of in a second, so what we call a stage procedure. And so that we don't know. There's some retrospective data, some European data where, they've got the great health system data where they can look, and it looks like taking the tubes out can really protect against ovarian cancer. So there's a big move afoot now to get tubes out. If somebody's going to have their tubes tied because they don't want any more pregnancies, let's not tie them. Let's just take them out. Right. And so anybody's going in for a gynecologic procedure that is done with childbearing, even if it was unrelated to ovarian cancer, we're starting to say, hey, should we take the tubes out now? And that way, just because you really, unlike the ovary, which you need for endocrine and hormonal reasons, you really don't need the fallopian tube once you're done having babies.
Sure.
Right. And so can we take the fallopian tube out? It's a very non-morbid procedure. What we don't know is, can you just take the tube out or do you need the tube and the ovaries? And that's a big question that's being asked. There are 2 big clinical trials going on right now to kind of ask and hopefully answer that question definitively.
That's great. We had a woman on our podcast not too long ago. Her name's Crystal. And she actually had the full hysterectomy, I can't pronounce it.
Salpingo-oophorectomy. Yes. Or they do something called TAHBSO, which includes taking the uterus out.
Yes.
That's a transabdominal hysterectomy by bilateral salpingo-oophorectomy.
Oh, I think we have a new tongue twister for the community. Yeah. But she was on the podcast and she was elated. It was like the best decision she has made. She made it in consultation with her oncological team based on all of her genetics. And I feel like she feels liberated now. Like you could just hear her smiling like through the entire podcast.
Yeah. So the early returns on these studies are women who are opting to kind of keep their tubes and ovaries in place when we're looking at some of these studies. They have a lot more anxiety, right? So I think there is a certain amount of like, phew, okay,
yeah, I've
done everything I can do. I don't have to worry about that now. And it's done. It's a challenge. One of the things I've actually discussed with some colleagues is, so I'm not a surgeon, I'm a chemotherapy doc, so I don't do the surgeries. But one of the things we've discussed is actually, if we're going to do this, could we just leave one ovary in? Because one ovary can carry the bulk of the burden. You will suffer menopause a year or 2 earlier, typically, if you leave just one ovary in. But if there is some residual risk from the ovaries, we could cut that in half by just taking out take out both tubes, one ovary, and just go back for the other ovary. And that is something that patients have opted for as well. it's a struggle when I've talked to patients. I have a good friend of mine who ended up being a BRCA mutation carrier and called me, what do I do? And kind of talking through that, it's a tough decision because there are reasons a lot of people want to leave that ovarian for hormonal reasons. There are real benefits. And so there are risks. But if you're a BRCA mutation carrier, obviously, there are real risks too. And until we know that it's 100% the tube, that's a tough decision to make.
Yeah, it's not black and white.
Right.
That's a loaded conversation.
It's a very difficult conversation. Yeah, it's very difficult. Yep.
Can you speak to some of the chemotherapies then that patients would potentially be on? I feel like I know a lot of them in terms of like the breast cancer field, but just for our listeners, what are some of like the rattle off generic names or pharmaceutical names of drugs they could be expecting to?
Sure. So a lot of the drugs will be similar to the breast cancer realm. There's a certain Venn diagram, particularly with the triple negative breast cancer. I'll say upfront, the standard of care still remains and has been for 30 years, carboplatin and paclitaxel. Those are the two drugs, paclitaxel, also known as Taxol, common in breast cancer. Those are the core therapy, the platinum-based drugs. So cisplatin is another drug. Sometimes we give the drug intraperitoneally in the abdominal cavity. In that case, we use cisplatin. They have different pharmacologic reasons for that. But the carboplatin, Taxol are the mainstay of therapy. Other drugs, other chemotherapy drugs that you will get that may happen somewhere down the line if the cancer comes back. Doxil, which is liposomal adriamycin. So adriamycin, very common in breast cancer. Drug called gemcitabine or Gemzar. Everything's got two names that keep them confusing. Topotecan is another drug people hear about. Bevacizumab is a drug that's a very hot topic that people in the last decade has become very popular. Very controversial data. Some people argue you should use it up front. And we know for patients who have very advanced stage disease, either patients who we can't optimally debulk. So that's an important term in ovarian cancer. And then can we optimally debulk? Can we get essentially the majority of the cancer out or not? So patients who can't be optimally debulked or patients who have stage 4 disease that's spread into the organs, into the lung, things like that. They get bevacizumab up front, they live longer. And so bevacizumab, also known as Avastin, should be used in that subset of patients. I'm a strong believer, but should not be used in anybody else up front. And that's a hot topic right now.
Sure.
Other therapies are coming into play. So the PARP inhibitors, there are 3 of those out there now. The patients will hear Lynparza, Rubraca, and niraparib. Those are all drugs that are out there. They can be used, interestingly, unlike in breast cancer, where it's really only the BRCA mutation carriers that benefit from PARP inhibitors. In ovarian cancer, about 50% of patients will benefit. The number one predictor is how well they responded to platinum, the platinum-based agents. So we are using those PARP inhibitors much more commonly now in the recurrent setting for anybody who responds to a platinum-based therapy. I would say those are kind of the majority of drugs. There's a whole, I can come up with a laundry list because, sometimes in ovarian cancer, patients can respond, progress, and we can do this 12, 14, 15 lines of therapy if somebody's strong enough and healthy enough. And so I can come up with a huge laundry list where we'll use some of the lung cancer drugs or other things. Immune therapy is starting to take hold. It's still not doing very well in ovarian cancer, only about a 10% response rate for, everybody asks, well, what about Keytruda or nivolumab, some of these other immunotherapy drugs? About a 10% response rate right now. And it's not the durable responses we were seeing in diseases like melanoma and thyroid cancer, kidney cancer. Not as good as we would like, lung cancer, but we're getting there.
Well, thank you. I think it's just so helpful too to just hear that running laundry list of so many times you meet with an oncologist and they rattle off all these terms and it can be very overwhelming. So anything in terms of education that we can bring out in front and say okay, I've heard this term before. I didn't quite know what it meant, but you know what? It's in my vocabulary now. You feel more empowered going into those conversations.
Yeah, good.
So I'm overwhelmed. I think I need to change my career into going into medicine. This is such exciting novel discovery and the work that McGee's doing and that you're involved in with the grant applications and, making headway. Yeah. How do you keep doing it? What's your drive?
So, but actually, I love doing what I do. And so I actually have the perfect mix. So if I had to pick being a physician versus a scientist, I'd be a physician because I love the interpersonal contact, but it is incredibly draining. And I could see where it might burn some people out, maybe myself included. Having the research lab allows the intellectual stimulation, the creativity, where I'm always doing something new, at least in theory, right? medicine, you get good at something by doing it over and over and over and over again. So you do the same thing over and over again. Whereas in science, once you've proven something, in theory, you don't keep reproving it. You move on to the next problem. And so it's a perfect marriage of kind of intellectual curiosity and excitement. But then I have the motivation of the clinic where I can see why I'm doing what I'm doing. I know why what I'm doing is going to be important for somebody. And then at the end of the week, I get a hug. So my clinic is the end of the week and I get hugs. And so it's a great mix where I can kind of do the hard science and I can fight with grants. I was talking with the NIH today and so deal with those frustrations. The patients keep me motivated. Yeah. And so the combination is fantastic. And so that's why I have the best job in the world. I love what I do. I say if I won the lottery, I would never write another grant, but I wouldn't change my job. Right? I would just keep doing what I do. I would just fund myself and then we'd move forward. So.
Fantastic. Well, thank you so much for being on our show today. I am so thrilled to have your time and your education and your expertise, just kind of sharing it with our community, especially because we know there's such a close tie between the breast cancer and the ovarian cancers that I know that this is going to be greatly appreciated. So thank you so much.
Delighted to be here. Always happy to share my passion.
I feel like we just scratched the surface, like so many more questions to ask. Thank you.
You're very welcome.
Thank you all for tuning in and listening to today's episode. We release episodes each week, typically on Mondays. If you have a topic idea or would like to be a guest on our show, please contact me at laura@survivingbreastcancer.org. We love hearing from you. Please remember that the content here should not be taken as medical advice. The content here is for informational purposes only, and because each person is so unique, please consult your healthcare professional for any medical questions. Views and opinions expressed on our podcast and website are our own and do not represent that of our workplaces. While we make every effort to ensure that the information we are sharing is accurate, we welcome any comments, suggestions, or corrections. In no way does listening, reading, emailing, or interacting on social media with our content establish a doctor-patient relationship. Until next time, keep on thriving.